Mental Health Task Force report. This is, I think, information, Bruce, for the board on how we're thinking about taking this subject forward. So perhaps, again, you'd care to give us a brief overview.
Thank you. I will be brief, Chair. I mean, it's clear that the NHS needs to improve its offer to people with mental health problems. And I think I'd like to reiterate Simon Stevens' thanks to Paul Farmer and Jackie Dyer for the work that they did on the Cancer Task Force, which led to a recent publication in the last 10 days or so. What is, I guess, is clear to me is that there is a difference in the way that we approach mental health to the way we approach physical health or mental illness and physical illness, and that there are deep-seated structural, cultural, and clinical differences. So the task force report aims to try and get underneath some of those, but the point that I would like to make is that this will not be easy. It will be very difficult, and I'll just come back to that in a second. But the recommendations out of the report broadly fall into three main areas. One is to provide a better 7-day service for people with a mental health crisis, and in particular a focus on liaison mental health crisis resolution and so forth. Secondly, to try and bring together the way we look at mental health and physical health. And there are many examples, really, of where the two have an adverse synergistic effect on each other. And then the third area is how we promote good mental health, both in the workplace, for offenders, and for ordinary people. And I think those are three very important areas. But I'll go back to my remark about the deep-seated kind of structural and clinical and cultural differences to say that they are sufficiently deep-seated and people have tried to tackle these issues before. I think it's going to be very important for us in our governance processes, and that the governance structure is outlined on page 5 of the paper, to understand what progress we're making, how fast we're making it, and where we're making it, and also to understand what other parts of the system might be inhibiting that process. So dealing with mental health is not just an issue of the NHS, it's an issue of work that's done by DWP, it's an issue of housing, it's an issue of veterans' health, it's an issue of offender health, and so forth. So it's a complex issue. You will notice that attached to the paper are a number of recommendations which come out of the report. I think largely the lion's share fall to NHS England, but many recommendations also fall to other jurisdictions in government, and Jeremy Hayward is fixing up a group to oversee how those particular areas might be tackled.
Good. Jane, any comments?
I'm welcoming the report, and what's been really helpful from my point of view is the synergy and the link between so many other of our national priorities. So, as Simon referred to earlier, we published the maternity review earlier this week on Tuesday, and actually, if you look at that, the emphasis on perinatal mental health is an absolute priority, and it's really helpful to see that it's also one of the key recommendations in this. So you can see that there is a general view about what is the right thing to do, and that's been really important. The other areas for me, when you look at our national priorities, is the support in here for 24-hour crisis support, which is absolutely essential in managing urgent and emergency care. And there is a synergy between this and the work we're doing on learning disability around physical health and things like employment, both of which are really important for people's mental health, but also direct links with the other work that we're leading. So I think that I absolutely welcome it and look forward to supporting Bruce in its implementation.
Good. Chairman, may I please just add to what Jane has said? We also want to see that we look at many of our other clinical priorities through a mental health lens. So, for example, when we look at how we stress test our implementation of the urgent and emergency care review, one of the areas that we include in that is mental health, along with some other cohorts of patients. And secondly, we will also include it, of course, in the implementation and deliberations which surround the cancer task force implementation.
Okay, questions, Victor?
Just how and when are we going to measure progress?
I think that's something that we're going to have to discuss at the implementation board, but I would suggest that the board might want to decide a time frame, a regularity at which we bring reports back to this board.
Can I sort of add to that? Clearly, we're working very closely with the team and the task force team, who are working through a plan for how the recommendations will be taken forward into implementation. That's one of our 10 priorities for next year for NHS England, and we already are working out what the key aspects are that we will need to implement during 2016. In fact, we're working on a 3-year programme of implementation so that we can see what happens next year and the following 3 years. That plan will be part of our business plan, and our business plan will be published at the end of the year and agreed through this board on the 31st of March. So just so that you're aware, and we're all aware, that we'll be looking to track progress and report progress to this board on both that 1-year plan and looking forward across the 3-year plan. And the 3-year plan obviously needs to support and align with the 5-year forward view implementation and the work that is being done on sustainability and transformation plans as well in local areas. So that's how we're planning to track and manage delivery.
I think, Victor, maybe the point if I could put words into your mouth, maybe, I think given how challenging this area and this subject has been in terms of making demonstrable progress on the ground, and given the catastrophic impact on people's lives and actually in the economy more broadly because of the cost of mental health illnesses, stress-related illnesses, etc. Whilst it's for Malcolm to decide, I certainly wonder whether we should have a particular focus on this at a more regular basis than we might otherwise do, because it is has been historically in the health service such a challenging area to make real demonstrable progress.
Yes, those were the words that I was going to pull out of my mouth. But I think it's like
you and I to be struggling to find things.
we are yes, like puppet and master, beautiful. I think there is there's a couple of things. First of all, it is true what gets measured gets managed, and I wouldn't want the excellent to get in the way of the good enough. There are some leading indicators, so there are some people who have a far worse experience with the mental health service than others, so that's a clue. Perhaps we should start there in terms of the outcomes, and my view is that we should be seeing something quarterly, and we should see something back from the task force as to what that dashboard's going to look like, in the autumn. So we get a sort of dashboard, and then we get something to the board on a quarterly basis, because we've been here before, and the difference has to be that we actually measure progress this time.
Okay, so I'll feed that back to Malcolm as well. Ian, you're wanting to add?
I just wanted to add, I think I'd like to provide some reassurance that so 3 things. One is the new CCG improvement and assessment framework, which we've developed with lots of stakeholders, including Paul Farmer and our mental health colleagues, will include within it a suite of indicators in relation to mental health.
That is reassuring.
Okay. And our intention is that that then forms the basis of what will be updated reporting arrangements into the commissioning committee around system performance. Our aspiration is to provide clarity to all CCGs and ideally aggregated to the 44 transformation footprint areas supporting STPs, the baseline data on those metrics, and we're aiming to do that within the next couple of months if we can. Additionally, as part of the new CCG improvement and assessment framework, there will be 6 clinical priority areas where there will be a single aggregate score on performance, and one of those areas will be mental health. And Paul Farmer has agreed to chair, in essence, a moderation panel to provide some independent assurance on the overall performance in different geographies around performance on mental health. And then thirdly, I wanted to just pick up on Karen's point around sustainability and transformation plans, because we have a process for the NHS to come back with clarity about how it's going to deal with the gap between the baseline position and ambitions for where each locality will get to by 2021. And they will be submitting their plans for formal assessment by the end of June, and therefore we will in July have a clear sense of what concrete plans are in place to measure progress on mental health through that process.
Yeah. I chaired a parity of esteem group some time ago. Is that being, what's happening to that? Is that merged into this, or is it something that continues separately? Or I'd hate to think it was layered.
As I understand it, it is wrapped into this new governance structure, so that we have a single governance structure that links to the 5-year forward view, but absolutely takes responsibility for all of the work of the task force and delivery of the task force. And the advisory board, which will be chaired by Paul Farmer, feeds in as part of that process to make sure that the programme is delivering the intent of the task force.
Very good.
Perhaps I can respond further as well, just right in the here and now. We're in the middle of the operational plan round for 16-17, and on parity of esteem, we're looking for every CCG to demonstrate as a minimum they've invested the same amount of new money in mental health and learning disability services as they've invested in other services. That's already a planning criterion in the short term. And also, just in the next year, in anticipation of this report, obviously we couldn't anticipate everything, we're introducing some new commitments around early intervention psychosis and some wait time targets around psychological therapies. Clearly there's a lot more to do, as signified by the report, but we are trying to get ahead of that in the operational plan round and make some early changes.
John?
Just briefly, Chair, can I just ask you about training existing staff? Because I mean, the situation's a lot easier than it's been in the past, in the sense we've got high-profile media people declaring themselves to have mental illness. We've got lots of media coverage and BBC programmes and so on. But nevertheless, it's still a big stigma. And one of the issues that is often forgotten is that people with mental health die of physical diseases that they don't need to die of: cancer, heart disease, smoking-related conditions. So in a sense, we need to be thinking about the whole workforce and getting there in rather the same with the learning disabilities, to get their level of awareness up that these people are harder to get to, and how do we get round that resistance to treatment? Is that something that's on your radar?
Yeah, absolutely. So Health Education England have got some quite detailed plans that they're developing, that particularly looking at learning disability and mental health. And it's if they were here, they would say, Lisa, my equivalent, or the Director of Nursing and HE, will say that there's a layered approach where they are raising awareness and then doing more detailed work depending on what roles people have. So some of that might be about online training, which is much easier for people to access and do. But we know from the work I've been leading in learning disability that the impact of poor physical health means that people do die a lot earlier. And we have exactly the same issue with people with mental health issues. So they are working, and they're part of the teams that are looking at this in the round. So Health Education England working alongside us to make sure that the outcomes are right and that the education is appropriate for the needs of the patients.
Okay. Simon, anything? you'd want to add to this conversation?
No, I think practically speaking, the two key deliverables that the mental health sector is already committed to doing in 16-17 are the new waiting time standards for early intervention psychosis services and IAPT. Then over and above that, we've been set affordable and impactful set of to-do list by the task force in the areas that has already been described. The phasing of that we've got to get right over the next 4 years, but that's going to be strongly supported if we can have much greater transparency about what's going on inside the black box called the mental health system, including funding flows, levels of activity, and the clinical effectiveness of the work that's been done. And on all of those counts, frankly, part of the reason why users of mental health services has missed out is because there's not been as much of that going on as there have been in the rest of the healthcare system.
Okay. Paul, I guess I'm glad Simon said affordable, because my question was going to be about sort of money and resources. Clearly we have a business plan conversation to come, but you can give assurance within to reasonable degree that this is in good place?
Yes, the funding came in various forms. In fact, it's come in various stages. The SR, the spending review, was the final part of that, or the main part of that. But we have the funding to do the things which we are committed to do in the task force.
Good. Okay. Thank you.